Urodynamic testing is a key component for the evaluation of lower urinary tract symptoms of urinary incontinence and voiding dysfunction. Video urodynamics refers to the use of fluoroscopy in conjunction with multi-channel cystometrics utilizing radio-opaque contrast-based fluid. This provides the clinician simultaneous functional and anatomic assessment of the lower urinary tract. The objectives of this video are to describe the indications for video urodynamics, provide an overview of the procedure technique, and to show examples of normal and abnormal study findings. Conditions for which video urodynamics are indicated include known or suspected neurogenic bladder, unexplained urinary retention or obstructive voiding symptoms, complex urinary incontinence symptoms, complicated lower urinary tract surgical history, or conditions increasing the risk for poor bladder compliance or vesicoureteral reflux, such as a history of pelvic radiation, chronic cystitis, radical pelvic surgery, urinary diversion, or renal transplant. A fluoroscopy machine, preferably a C-arm, and a fluoroscopy-compatible urodynamics chair are required. Staff must be trained in the use of fluoroscopy, wear lead shielding, and monitors to track radiation exposure. Proper fluoroscopy techniques to minimize radiation exposure must be employed. Testing is typically performed in the sitting position, however, there may be indications for other positions such as supine or standing. Average fluoroscopy time is less than 15 seconds. This example of a normal study demonstrates the 5 points at which images are generally obtained. The first image is a scalp film to evaluate for any radio-opaque shadows or bony abnormalities. Next, an image is obtained during the filling phase to confirm correct positioning of the bladder catheter. Images are then captured during Valsalva or cough stress testing. A voiding film is obtained to capture the emptying phase. Arrows point out the location of the bladder neck and urethra. The last image is taken after completion of voiding. Patient number 1 has a history of neurogenic bladder and multiple sclerosis. Her presenting symptoms include urinary urgency, frequency, urge incontinence, and recurrent urinary tract infections. Urodynamic findings include a small maximum cystometric capacity and detrusor overactivity as pointed out by the arrows. Fluoroscopy demonstrates bilateral bladder diverticula near the ureters and leakage with detrusor overactivity. As seen in this post-void image, contrast remaining in the bladder diverticula may be confused with elevated post-void residual in patients with bladder diverticula. Patient number 2 has a complex history including 2 prior suburethral slings with subsequent sling excisions. She presented to our institution with recurrent stress urinary incontinence, incomplete bladder emptying, and recurrent urinary tract infections. Cystometrogram shows evidence of poor bladder compliance based on the volume-related rise in vesicle and detrusor pressures. Fluoroscopy demonstrates bilateral grade 4 vesicoureteral reflux as evidenced by bilateral hydroureter, dilated renal calyces. This Valsalva image shows a small amount of contrast filling the urethra consistent with urodynamic stress incontinence. The post-void images show incomplete bladder emptying and contrast remaining in the upper tract. No evidence of bladder outlet obstruction was identified. High-grade vesicoureteral reflux may affect the urodynamic parameters. The PVR at the beginning of the study may be falsely elevated as the bladder quickly refills with fluid from the ureters. Actual bladder capacity may be less than testing indicates due to a portion of the infused fluid filling the upper tract. Poor bladder compliance may be hidden by the effect of the instilled fluid preferentially filling the upper tract. Patient number 3 has a history of spina bifida and a complicated urological history, including neurogenic bladder and prior right nephrectomy. She presented with symptoms of urged urinary incontinence. Cystometrogram shows poor bladder compliance, again noted by the rising vesicle and detrusor pressures with bladder filling. Fluoroscopy demonstrates grade 4 reflux, producing hydroureter to the solitary ureter. Patient number 4 has a history of L1 spinal cord compression injury. After spinal surgery, she developed urinary retention and required clean intermittent catheterization. Cystometrogram reveals a small maximum cystometric capacity, poor bladder compliance, detrusor acontractility, and Valsalva voiding. On fluoroscopy, she was noted to have a severely trabeculated bladder, giving the Christmas tree appearance seen here. Patient number 5 presented with voiding dysfunction and incomplete emptying. Cystometrogram shows elevated detrusor pressures during voiding and low urine flow. Fluoroscopy shows an open bladder neck, dilated proximal urethra, non-relaxing sphincter, and small bladder diverticula. This is a classic picture of detrusor external sphincter dyssynergia. Patient number 6 is a patient with a history of neurogenic bladder due to a spinal cord injury who presented with urge incontinence and recurrent urinary tract infections. Video urodynamics demonstrates a small systometric capacity, detrusor overactivity with leak, an open bladder neck, and dilated urethra. Patient number 7 presented with mixed urinary incontinence despite a history of multiple medications and anti-incontinence procedures. She also had a history of urethral diverticulum which had previously been repaired. Fluoroscopy during the voiding phase demonstrated a recurrent urethral diverticulum. Video urodynamics has several important advantages over conventional urodynamics for the evaluation of patients with lower urinary tract symptoms. It gives the clinician simultaneous functional and anatomic views of the lower urinary tract. While this can be of great benefit for specific patient presentations, the advantages do not come without potential risk. Financial costs and risk of radiation exposure must be weighed against the benefit. Nevertheless, in complicated patients, as illustrated here, video urodynamics may be invaluable in evaluating complex lower urinary tract dysfunction. I thank the committee for allowing me to present this video. I will now receive your questions.